Great. Well, welcome to everyone. And we are recording this. And I'm Scott Podolsky, and our Department of Global Health and Social Medicine is honored this spring to co-host multiple seminars devoted to the health of Indigenous peoples. And for this, we're grateful for the wisdom and input of my colleague, Dr. Joe Gahn, and I get to help co-run the seminar series itself. This is a key part of that series. Now I'll get to introduce Professor Gahn, and he'll have the honor of introducing today's speaker, Dr. Alexandra Adams. Joseph Gahn is Professor of Global Health and Social Medicine in our department, a Professor of Anthropology in the Faculty of Arts and Sciences in Cambridge. He's collaborated for over 25 years with American Indian and other Indigenous communities to rethink community-based mental health services and to harness traditional culture and spirituality for advancing Indigenous well-being. He's an enrolled member of the Menominee Tribal Nation of Montana, and among many other roles, is the director of the Harvard University Native American Program and an elected member of the National Academy of Medicine. So with that, I'll hand this over to Dr. Gahn.
Thank you, Scott. It's really a pleasure to welcome all of you to this, which is our final of 4 Indigenous Health and Wellbeing colloquia that we've hosted in partnership with the Department of Global Health and Social Medicine and the Harvard University Native American Program. I'm really delighted today to welcome Dr. Alexandra Adams to share with us her research and professional work committed and dedicated to improving the health and well-being of Indigenous peoples. Before I start, let me please first offer an acknowledgement of Land and People. The Harvard University Native American Program collaborated with leaders of the Massachusetts tribe of Ponkapog to develop this acknowledgement. Harvard University is located on the traditional and ancestral land of the Massachusetts, the original inhabitants of what is now known as Boston and Cambridge. We pay respect to the people of the Massachusetts tribe, past and present, and honor the land itself, which remains sacred to the Massachusetts people. Today's speaker is someone I've known for a little while now, and I'm really delighted to welcome you, Dr. Adams, to talk to us today. Dr. Alex Adams is the director of the Center for American Indian Health and Rural Health Equity and NIH Phase 2 COBRE at Montana State University here in Bozeman, where I happen to be talking to you from as well. She is Professor Emeritus at the University of Wisconsin School of Medicine and Public Health, where she also practiced family medicine and pediatric obesity treatment. The foundation of her work is community-based participatory research, working in partnership with Indigenous communities to understand and solve health challenges using both scientific rigor and crucial community knowledge. She has directed multiple community-based clinical trials and received over $40 million of NIH and foundation funding. Her work focuses on promotion of family and community wellness and healing trauma through community building, climate change and human health, and a current randomized clinical trial of home-based COVID testing in underserved communities. She also uses storytelling, filmmaking, and other outreach strategies to engage communities and impact health. She was elected to the National Academy of Medicine in 2021. We were, I guess, classmates, if you think of it as that way. A very exciting time for us. And today, Dr. Alex Adams will be speaking to us on belongingness, impacts on Indigenous, individual, and community health. Alex, please take it away.
Yeah, thank you so much, Joe. It's such a pleasure to be here and be with everyone today. I'm going to do the screen sharing thing. And hope you can all see that. And I will start the slideshow. Joe, you can see everything? I can't hear you.
Very good.
Okay, excellent. All right. I'm going to do a land acknowledgement for the land that I'm currently on, that Montana State currently sits. So I acknowledge and honor the Indigenous nations and peoples on whose traditional homelands and ancestral territory Montana State University now stands, and whose historical and cultural relationships with the land continue to this day, including the Crow, Kootenai, Nez Perce, Lakota, Blackfeet, Pend Oreille, Salish, Shoshone, and Northern Cheyenne. So yes, our mountains do still look like this. We still do have snow here in the mountains. I'm going to talk about 3 things today. The first, what I want to do is talk about the Menominee Journey to Wellness. And the Menominee Journey to Wellness is work that I've been doing with the Menominee Nation in Wisconsin for the past 20+ years. And then I'm going to talk to you about the dissemination work that we're currently doing based upon a number of years of NIH-funded research in obesity prevention and wellness promotion for Native American families with young children. And lastly, I'm going to cover what I currently do at Montana State University in the Center for American Indian and Rural Health Equity, or CAIRHE, as we like to call it. The theme of my work today is really going to be about belongingness. I'm trying to tie this all together. And initially, I want to start with this sort of more academic sense of the term. This is not my area. It's a big area of study in psychology, but I think it's useful to connect the talk today and to connect the work that I've been doing over this many years. So belongingness is really a sense of connection to community. It can be defined as an emotional need to be accepted as a member of a group, family, friends, community, religion, or something else. And it's a basic need in human nature. And this desire and need is so universal that it's found across all cultures and different types of people. So to just touch on a couple of studies of belongings to kind of give a little bit of an academic base here. In 2007 and 8, there's a large Canadian community health survey that asked a very basic question about sense of belonging to community in a large health survey with people across the spectrum, urban, rural, across a demographic. And regardless of demographic, they found a very strong association between sense of belonging with self-perceived physical and mental health. So if you felt that you belonged more to your community, you reported better health. And you also reported less stress, which is really interesting. And I want to turn now to work that was done by one of our junior investigators here at Montana State University, Neha John Henderson. And she's been working with the Blackfeet Nation for about the past 4 years. And she asked this question, similar kind of question. She worked with students in Blackfeet Community College as well as faculty there to create a belongingness survey. It was about 5-question survey. And then they wanted to understand whether that moderated the relationship between childhood trauma using the ACE score, or Adverse Childhood Experiences Questionnaire, and immune system inflammation measured by C-reactive protein and interleukin 6. And so in 90 adults, they asked this question. And really interestingly, she found that the association between ACE score and inflammatory markers was only significant for those people who reported low levels of belonging. And in fact, there was no association of those two in individuals reporting a high sense of belonging. So she's working with that community to further this research and understand more of what may be going on. But this is really intriguing in terms of what may be happening in terms of could enhancing sense of belonging actually increase health. So I'm going to take a little pause here and I'm going to tell you the story of why I do what I do. What really gives me the honor of being with you here today and sharing my stories of research partnerships with communities over the past 22 years. And it's also the story of how I've come to understand belongingness and began to understand belongingness, although I didn't call it that at the time, from a much deeper perspective. So many years ago, when I was a young MD PhD student in Central Illinois, I was called to South Dakota to go do a rotation on the Rosebud Reservation, family medicine rotation for 4 weeks in August. So my husband and I drove across country. He was also a med student at the time. And I didn't really know why I wanted to go there, except that I thought I might want to work for the Indian Health Service in future. And it seemed like a really good opportunity to get out of Illinois. So we drove past miles of wheat fields in Nebraska and miles of corn and soybeans, and finally got to the edge of the reservation. And it was a beautiful August sunny day. And we drove into the reservation. And if you've ever been there, you know it's very beautiful and very isolated, lots of rolling hills. And we stayed in the barracks, which was for the medical personnel there. And I worked in the emergency room and delivered babies and worked in the clinic. But my most, I think, impactful time there was driving around the reservation with one of the community health nurses. And she really taught me about the reservation and what was life like there now and what life had used to be like, and the checkerboarding on the reservation, and really opened my eyes to what it was like to live there. And also, we got to do a lot of really beautiful things like childhood immunizations and diabetic feet management and tuberculosis. But she taught me so much, showing me how little food there was in people's refrigerators, how commodity foods were the primary foods, high salt, high fat, high sugar, trucked in USDA foods. And then, of course, I'm thinking to myself, they truck in the doctors to fix the diseases these terrible foods cause. But I remember driving past these beautiful rolling hills, and she would point out her favorite spots to pick sage or other wild herbs. And once when she drove past a small lake, she told me it was called Chase's Woman Lake. And she laughed and said that was because her brother had helped form the lake and he liked to chase women. And she had this beautiful laugh, and she could hold the pain and suffering of her people and her hard job and all of that with her humor and belongingness to that place. And so while I was struck by the immense health challenges, what I was most touched by was a sense of community there. And this was that cohesiveness I was really just so impressed with, from the powwow to the Sundance we were invited to attend, and especially those home visits, the feeling of knowing everyone, every part of the landscape, the plants, the animals, and the people, all being connected in a way that I'd never experienced before. And this sense of connection to place and people was really a revelation to me, as I grew up in New York City, which anybody that's ever gone there knows it's one of the most disconnected places on the planet. And so when we drove away at the end of that rotation, I knew that I wanted to learn more. And so it's, as I look back on that now, many years later, it's clear to me that I still have much to learn, but that belongingness is a really key part of that. So while we talked about belongingness as that sense of connection to community in the beginning, I think it's also a sense of being part of something bigger than yourself and a sense of your value as part of and a contributor to that bigness. So I'd like to start with my work with the Menominee. So the Menominee are in, this is their reservation. It's contiguous with the borders of Menominee County, and they are in northeastern Wisconsin on the shores of Lake Superior. And it's a beautiful reservation with amazing trees, and you can actually see the forest from space. It's got the longest sustainably harvested forest in the United States. And they're called the People of Wild Rice. And here are some pictures from the way life used to be that we have that show Menominee are big weavers. They were big gardeners, a lot of squashes and different things, and of course, wild ricing. And when I came to work at Menominee, I was first there as a medical resident. It was my last rotation as a resident, and I was 8 weeks pregnant with my daughter, who's now 24. And it was a wonderful experience, and I loved working with everybody there. And Jerry Waka, who was the health director at the time, and he's still the health director there, sat me down at the end of the rotation and asked if I'd stay. And I said, well, I really want to work on prevention. So I really want to connect to the university and not just be a doctor on the reservation. So he didn't think he'd see me again, but we laugh about that now. So again, the health in Menominee County is quite complex, as it is in most tribal communities. They currently rank 72 out of 72 counties in the state for their health, with all of these kinds of issues that you commonly see. But this doesn't tell the full picture and how hard they've been working and all of the changes that have really been amazing for me to be able to witness as I've walked alongside them for over 20 years. So when I first started there, they were doing this basic public health approach to prevention, as was I. Looking at things like using logic models, using a pretty typical approach to prevention. How do we change policy, system, and environment? And none of those are bad, but it wasn't making a big impact. But we were really lucky that we had two major community champions. And on the top, you'll see Jerry Waka in the yellow shirt. And again, he's been the health director for many years. And he is just a wonderful advocate for his community. And then his brother Wendell in the pink shirt, who's a school superintendent. And they have worked really hard to pull people together in their community to make a difference. And they started something called the Menominee Community Engagement Work Group, or the CEW. And this group started out really small and about 4 people in a room, and then has expanded to over 70 people now. And it meets quarterly. And the mission is really to look at how do they use the Menominee Tribal Strategic Plan to think about building a healthy future for the community. So they have where they were in the past in terms of health, where they are currently, and where they want to go. So they have a long-range vision but they break it down into these 90-day action plans, and they have a wonderful facilitator who comes in and helps them do that. And she's from outside the community, so she's great because she can tease everyone, which is really helpful, including all the academics involved. And those 90-day action plans really move the needle, because people can celebrate those small successes and then make a big difference overall over time. So when we started with that group, it was 2011. We'd already been doing about 9 years of work on childhood obesity in terms of NIH grants in the community, looking at prevalence, looking at some prevention. But the CEW felt that continuing to focus on obesity would be kind of low-hanging fruit. People would all get behind that. They all wanted healthy children. And then as we started to meet and talk, realizing that there were other issues that were really critical in the community. And so school readiness came to the fore, and then teenage pregnancy came up, and we added those as issues to work on. And then through a lot of work that Jerry and Wendell were doing, they started to do ACE scores for everybody that was providing care to others in the community. And they realized that there were very high levels of trauma. So started to build in trauma-informed care, and we developed the Menominee trauma model, which I'll talk through in a minute. Because we got to be so big and so many things were going on, it got a little scattered. And so the trauma model helped bring people together. And then because of the huge success that the community was having, they developed this process as a model for cross-agency work in 2015. And they also won the RWJ Culture of Health Prize for all the amazing advancements that they had done by then. And Wendell was invited to go to the White House and talk about his ability. He had worked with the school district and the school to increase graduation rates from 60 to 90% in that community. We then began a fairly large project on collective impact and community organizing that culminated in the development of a really nice nonprofit in the community. And by 2016, it represented the majority of organizations in the community. And then in 2018, after a number of presentations nationally and internationally, we created a wellness model that I'll also talk through. So this is the trauma model. It's gone through many iterations, probably over a period of 5 years, had things added and changed by that community engagement work group. But as I said before, it was the result of understanding that unhealthy behaviors in the community, such as substance abuse or teenage pregnancy or lack of self-care with low physical activity or not eating right, and disconnection, were really driven by adverse childhood experiences and this historic trauma here that you can see in terms of loss of language and culture, loss of land, the termination area. This tribe was terminated and took 20 years to get reinstated, the boarding school area that most tribes have experienced, and then just overall genocide of Native peoples in general. And then of course, current intergeneral risk perpetuation with lateral violence and that kind of acceptance of dysfunction in the community, leading to kind of a survival mode. So all of this, of course, is what's behind all of the other things people are working on. So it really helped people who are working in very different areas, people who are working in obesity prevention, people who are working in diabetes, people who are working in AOTA, really come together and say, okay, we're all working on the same thing. And it made a big difference to the CEW to sort of have this model and understand that. And then we were invited to share our work in a series of 4 Indigenous knowledge exchanges by this crazy gentleman here, Ihi Heki, who's Maori from New Zealand, and also Boyd Swinburne, who's an academic at the University of Auckland. And we just had a wonderful time with those exchanges and learned so much about what other communities were doing, and was really empowering. This is our first trip to New Zealand, and you can see this is our smaller group here. This is Jennifer Gauthier, and Jennifer and I went on all these trips together. She is a Menominee extension agent, and she's part of the Menominee Nation, and she you'll hear more about her as we go along. This is me presenting the model at that time, which was called the Broken Hoop model, one of the beautiful marae down here that we got to stay in. And then we did a lot of outdoor work, learning about their plants and their landscape and natural foods. And this is a fern that you can turn over and it glows in the dark so you can see your way at night. So we also got invited to Hawaii and worked with several Native Hawaiian communities, understanding their revitalization of language and culture through traditional gardening. And beautiful, huge gardens we got to visit and hike through. And a lot of them have many kids that are engaged in learning on the land, which was really special to see. And of course, they're doing a lot of aquatic work. And this is just an example of some of the wonderful traditional foods that we were able to eat there. And then we were able to bring that whole group back to the Menominee Nation. This is a picture of Guy talking about the Wolf River and just sharing the sacred importance of that river to the Menominee, as well as we went to the Flathead, and several of the canoe builders there got to talk to the Maori canoe builders. So that sharing was just a very special and important time for all of us. So we took that trauma model and we talked about it in all of these settings, and it resonates with many different communities in many different settings, because a lot of communities, Indigenous and non, of course, have experienced much of this, particularly obviously African-American communities. But we also knew that that wasn't the answer. This was just sort of what the problems were. So when we got back, we created or finished creating what we call the Menominee Wellness Model. And this model really embraces healing in all aspects of health: physical, mental, spiritual, and emotional health, and embraces traditions, language, culture, heals historic trauma, and reclaims that identity that's been lost, but also creates new traditions and creating meaning, connection in new ways, and building trauma-informed communities to create healthy relationships. Hopefully increasing positive parenting, and then by doing so, strengthening nations and improving wellness. So what I think this is really saying is that belongingness, this kind of belongingness in the community, is really critical to health. And we continue to work on this model today. I wanted to give one example of the work that came out of those Indigenous exchanges and came out of the work of that model. And this is work that Jennifer Gauthier's really been promoting through her extension work and through the College of the Menominee Nation and through the tribe's health organization. So they used to give out seeds, like just it's May or whatever. I mean, we're going to just put seed packets around the reservation and everybody can pick up seeds and go garden. And they would provide sometimes seed starters or, rototilling. But it wasn't until they started to really transform the way that was done that it really got to be something exciting for the community. And so now there's a seed blessing and dance and song, and the kids up here are packing the seed packets for everyone. And there's teachings and information about all the traditional seeds. So really, again, strengthening that community and intergenerational learning and bringing in Menominee language and culture, really critical to doing that. And here are some pictures of the kids. Here's the kids in one of the community gardens. Again, like their ancestors, learning how to garden and learning what that means and learning those connections. And then Jennifer also does a weaving class where she teaches kids to weave in traditional ways. And these girls actually got to go on an exchange to New Zealand as a part of youth exchange, which was really special for them. So I want to say Anek Waiwanen to the Menominee for having me be part of this work and work with them for such a long time. And I'm getting to go back there in May again, and I'm really looking forward to it. It's been hard with COVID to travel enough to see everyone. So we're going to go to the next slide. And we've talked about the Menominee Journey to Wellness. We're going to move on now to Turtle Island Tales, and then we'll finish up with CAIRHE. So Turtle Island Tales started out as 2 randomized NIH clinical trials called Healthy Children, Strong Families. And we started in Wisconsin with 4 communities in Wisconsin. And we had done some studies knowing that adults and children had high levels of overweight and obesity. And we wanted to work with these communities to improve the health of those families. And the communities really wanted to use an elder approach of life skills and values to the next generation. And so we chose for the first trial a home-based intervention. It was going to be delivered by community health workers or mailed in, which was the control. And it was for families with children ages 3 to 7, because we saw very early overweight and obesity levels. And the first Healthy Children Strong Families 1 did show improvement in nutrition for adults and kids, activity levels, and body weight parameters for about 150 families. But interestingly, we found no difference between the control group and the group that had the home-based. So we did a much larger trial across 5 communities that I'll show you in a minute, with 450 families, where we added some things, and I'll show you what we added. And we also just mailed it in. So in the first trial, we looked at increasing activity, decreasing screen time, increasing fruits and vegetables, decreasing sugar and soda consumption, sweetened beverages. But then because we saw so many kids were up really late at night eating and their parents were stressed, we added in improving sleep and improving stress management. So here's some of the key findings from that second study. And it was a 1-year kind of crossover design. And what we found was that we got significantly improved adult and child diets, adult physical activity improved, and adults showed a readiness to change in several important measures. We also showed a trend for reduced screen time for children, and the families really loved getting the program. One of the things we heard constantly was, we loved getting the package in the mail. It made a huge difference. My kid loved getting a package with their name on it, and we were able to interact together. And I'll show you what was in those packages in a minute, because we've improved that with Turtle Island Tales. But we also found extremely high rates of food insecurity. We had anywhere from 50 to 60% in the reservation communities to about 80% in the urban setting that we were in Albuquerque. We found Facebook was a really important recruitment and retention tool. People's cell phones turn over a lot in communities, and so, but Facebook doesn't. And we also noted in our qualitative work that families spent a lot more time reading and eating together, which we wish we'd done more quantitative work on, because I think that was a huge outcome. And this is just one of the papers that we published. So I'm just going to say thank you to all the communities that were involved in the study. First, the Menominee that were involved in both trials. Lac du Flambeau, Bad River, and Oneida were involved in Healthy Children 1. And then Seneca Nation, White Earth, First Nations Community Health Source in Albuquerque, and the Blackfeet were all involved in the second trial. And this is just one quote from one of our parents about what the program meant to them. We had some really beautiful quotes, and we were very grateful to have community health workers who helped with the study in each of those communities that helped us adapt it and get it out to their communities. So some of the challenges, of course, of a huge study like that are that we had 3 different time zones. We had family level challenges. We had, some families that changed where they lived, so packages got returned and we had to work on that. And of course, we had a lot of cell and internet service interruption, as you would expect in rural areas or people who are living month to month incomes. The successes, we did have local community members, as I said, at each site helping us administer the study. We had 100% recruitment, and retention was 16% over 2. Well, we only lost 16% of people over 2 years. So 84% retention rate was really good. A lot of positive behavior changes, and participants loved it. And we saw that we feel that we were helping to increase family resiliency, and there were some positive community level changes that we can talk about in the Q&A if anybody's interested. So we started to present this to lots of different places. We would go to national meetings or Native conferences. And the question we got asked the most is, how do we get this program? How can we do that? So we started to ask ourselves, how are we going to do this? Because we don't know how to do dissemination in that way. So when I was recruited to Montana State University from UW now almost 6 years ago, I created a small group of Native elders, and we sat down and thought about what we wanted to do next. And we created something called Turtle Island Tales, which is this sort of larger platform that we're using to disseminate the work. And as you can see, it's a turtle based on the story of the Turtle Island. And we have a leaf here as on his back And each of the 7 sections represents one of the 7 grandfather teachings that's part of the new program. So the mission of Turtle Island Tales is really to do that holistic view of health and creates physical, emotional, spiritual, and mental health for families with young children and the next 7 generations through the story-based platform. And this is a quote from one of the elders that works very closely with us that you'll see in a minute. And Darnell has just been so lovely and helpful to us. But again, this is about belongingness. Know who you are, know where you come from. This way you know the path you are on. So thank you, Darnell, for all that beautiful work with us. So here's our team. We have Emily Salloway up here, who's Blackfeet, Darnell, also Blackfeet, Jennifer, who's Menominee, and then Amy, who's not pictured from the Choctaw Nation. She is now a medical student, so works with us just a little bit on and off. And then we have an academic team, including Emily Tomeko, who's been with the project for over 10 years. And I also really want to highlight the MSU ABLE group. So this is a group of Native students that are studying business, and they came and worked with us to create our business plan and actually presented it then nationally and won twice, two different awards. So that was really exciting for them to get the national award. And Terrence Limpy here still works as an intern with us, and we couldn't do without him. We have a really great creative team, including filmmakers and a screenwriter and graphic design team. And then here's some scenes of filming, and I'm going to show you some of our video work in a minute. So the structure of the program consists of 12 lessons. They each get mailed into the home over a 1-year period, again, for kids 3 to 8. There's a printed caregiver lesson booklet, a children's book that's topical for whatever the topic is, some other wellness support items I'll show you in a minute. And then we have trying to work on pretty strong social media support. So here are just some of the topics like healthy snacking or naturally sweet, to talk about fruits and added sugar. We did add some emotional regulation this time because we realized that a lot of children and families were struggling with how to manage emotions in their kids. So here's just some sample support materials. You can see each of all of these books. We have something called the Move Cue, which is a really fun thing that rolls and plays a game. We've got finger puppets and stickers and a lesson for the kids, bandanas, more stickers, recipes for the parents. Got 2 of those. So this has a real holistic approach, again, looking at all of the aspects of health. And in each of the lessons, we call out which pieces we're going to be working on. This is a picture of one of the parent lessons. This is our little Igmu. He was named by a grandma advisor of ours on the Fort Peck Reservation now about 4 years ago. It means cat in Lakota. And he helps the kids relate to his little emotions and feelings and ups and downs. And then Grandma Darnell can help him regulate and model that for all the parents. And it comes like this in home use for parents and kiddos. So this is a website and social media content, and you can look us up and check us out. I'll show you that in a minute. But again, a lot of nice design by the design team, much nicer than what it looked like in Healthy Children, Strong Families when it was mostly clip art. So I wanted to show you a compilation of 2 of the short films that we have done so far. And this first one, Igmu's Teepee Dream, is much longer and is the story of the little bobcat Igmu having a bad dream and his grandma telling him the story of the teepee to get him back to sleep. And then the other compilation in this little short section you're going to see is from a video we did very early on in the pandemic, which was about why kids had to wash hands and why they had to be social distance from grandparents. So I'm hoping this is going to play for you.
The teepee rests on the earth in a circle like the sun and the moon.
Grandma, where are the buffalo?
They are coming, Igmu, but you must listen as a buffalo listens with respect.
And you need to keep washing for 20 seconds.
20 seconds? Probably my paws will melt.
I'm so proud of you, Igmo. I do love you.
All done. Can I do it again?
So those are our films, and we've had a lot of fun making them, and I'll tell you where we are now in that film world. But first, I want to tell you about the partnership that we currently have with Blackfeet Nation and Montana State University Extension. And we are working on beta testing of this program to see how it rolls out as an evidence-based program, but with these additional components. And we've recruited 57 families currently, and they are in month 4 of the project. So looking forward to see how they're enjoying it soon. So here's how you can reach us. You can get on to turtleislandtales.org and you can see the full 2 films. You can find us on Instagram or Facebook, and you can contact us at turtleislandtales@gmail.com. So those are ways to reach that group. And excitingly, we learned very recently that we were accepted as a SNAP Ed curriculum. And for those of you that don't know, SNAP Ed is the national way that education is given to people who have SNAP Ed dollars, or what used to be called food stamps. And so we've become an included curriculum. So we're very excited about that and how that will help us with dissemination. And then we are also having fun working with Montana PBS that is working on a series of 3 short films about Indigenous foods of Montana. And here you can see Grandma Darnell teaching little Igmu how to make Salisbury soup. And this is a picture of my basement that has Igmu's bedroom in it, where we do those shots, and she's telling him a story there. So just take a breath here and say thank you to everybody working on Turtle Island Tales. This is a picture from one of our beautiful New Zealand trips. And I want to go over a few of the lessons that we've learned from all of this work. So first, I think people coming together with a common vision and that common sense of what they want to do is just so powerful. And I've really been blessed to experience that and be part of so many different groups doing that. And I think the other thing I've really learned, and I don't think we get taught this enough as physicians, but that people's whole selves need to be engaged. We have to really engage them in mental health, physical health, spiritual health in order to really address health fully. And then, of course, Indigenous knowledge and understanding the root causes of community issues is absolutely critical. And again, this gets back to that common vision, but that multi-sector partnerships and bringing people in that you don't expect to bring in really help move beyond trauma and into action. And I can share more of those examples from Menominee if people want the question session. I also think that long-term partnerships really, I didn't learn half of what I needed to learn with, working with Menominee until about 10 or so plus years in, and we're still learning. So I think the longer we can really commit, the better. And then what we're learning with Turtle Island Tales is dissemination is complex and is fun, but takes a lot of work. So again, we went through Menominee Journey to Wellness. We've talked about Turtle Island Tales, and now we're going to switch to the center work that I do. And when I first came to CAIRHE, it was called CHRM, the Center for Rural Health Equity, something, I forget what the M was. Anyway, it was really a great thing that it was set up. It was a beautiful center, but it was really a funding mechanism. And many of the people who were funded viewed it as that. They didn't really understand what a center could do for them or how it could really help them become who they wanted to become in terms of their own faculty goals, but also how it could really help inform their work and make them just have a much better sense of cohesiveness within their group and community. So the mission of CAIRHE is to really work with rural and Native communities across Montana to create interventions that ultimately will improve people's quality of life and save lives. We are NIH funded, as Joe mentioned in the beginning. We do practice community-based participatory research, so all the communities have community advisory boards. They all work with everybody in the beginning to design the research and think what they want to do, and then analyze it and then disseminate it. And we've got multiple disciplines. We have people all the way from nurses to health and human development, to sociology, to engineers. I think engineers maybe, trying to think who else. Oh, psychology, of course. So lots of different disciplines. And you can see we've had projects by these red dots in all of the reservations and in multiple rural communities as well. So this is a kind of a busy slide, but it really talks about how we're organized. And I want to just point out a couple of important things. I've got really fantastic administrative core support. And we have a wonderful external advisory committee, an evaluator that helps evaluate us, and internal mentors that mentor our projects. We fund about 3 large projects a year, and they're funded anywhere from 2 to 3 years before they graduate from us into their own independent NIH, NSF, or other larger funding. We also fund anywhere from 5 to 7 pilot projects, and those will graduate into research projects or into their own funding on their own. We have a biomarkers core that does a lot of our lab work for us. And then we have a really important core called the Montana IDEA Community Engagement Core. And we share this core with another large grant called the Montana IMBRI. And that center has been around 18 years. And they actually helped birth our center in terms of writing the grant for the center and then helped recruit me here. So we work together on a number of different things that I'll talk through in a minute. And that core is becoming really integral. And many of the folks that work in that core then support these projects. So we're working to create something called the Health Equity Network. And so Montana's a very big and very isolated rural state, and we don't have a medical school. We have the University of Washington's medical school, so it's a whammy state, and we've got about 30 medical students, so not big enough to have a big research enterprise. So we have to reach out to lots of other partners in order to create that medical research sort of feeling or ability that we would not otherwise have. And some of those partners are within the state, such as Montana Public Health Association or Billings Clinic, but many are outside the state, such as the ITHS at the University of Washington, which is their CTSA and has been really a big partner for us recently. The University of North Dakota School of Medicine is just coming online as a partner, as is the University of Utah Huntsman Cancer Institute. So while our primary close research partners are, of course, the tribes and communities and other programs in the state, and at the research sites, we also have all these other partners that we're building. And here's how we help our faculty investigators. So I love mentoring. And one of the things that I think we do best is we help mentor faculty to help them succeed as faculty and then balance their what's quite difficult work sometimes with communities. And I'll show you why in a minute, but that has a lot to do with distance and just commitment. So each of the faculty investigators gets mentoring by me. I'm the PI of the grant, has a mentor that's their primary mentor within the center. They have an external mentor, often who's a content mentor, because we don't often have everybody studying everything at Montana State. They get mentoring by our external advisory committee twice a year when they come, and that's really helpful. And then our community research associates that do a lot of the research work to the rural and the tribal communities often take those faculty into the communities, teach them how to work with the communities if they don't know that, help them set up community advisory boards, and really, really are absolutely critical to the success of the work that we all do. And then they mentor each other. There's team mentoring where we get together once a month and we break into small groups and they mentor each other. And often that's around life issues as well as faculty and teaching issues. And then we have an annual mentoring retreat where we work on some form of leadership piece and generally have fun together. I want to highlight some of our CAIRHE faculty for you. I'm going to start with Vernon. Vernon is Blackfeet, and Vernon's been with me since he was a postdoc at UW, and he was the first distance postdoc at UW because he has a family and lives on the Flathead and couldn't move. But Vernon has a KL1 grant now and is doing beautiful work on the Blackfeet, understanding and collecting traditional stories about sleep and sleep habits and dreaming, and trying to improve sleep quality for adults and children on his reservation. And there's Vanessa Simons, who was one of our graduates. She's Crow and works with Crow on water quality projects, and graduated, I think, 2 years ago to an NSF grant. And then Emily, who I mentioned earlier, works on a number of projects. She has was also a postdoc at UW and then a faculty at Oregon State University, and now is here as faculty in health and human development. And she is an R21 looking at rural schools and 4-day school weeks, as well as working with Warm Springs on their traditional foods toolkit. And this is Monica, and Monica is a psychologist. She is also one of our mentors in the center, and she worked with the Fort Peck community, has been with them probably about 8 years, and works with them reducing alcohol and drug recidivism through a community designed program looking at how traditional ways can help. And belongingness, again, even though she doesn't call it that, can really help reduce recidivism. And then Neha, we talked about earlier, is continuing her work with the Blackfeet Nation. She just got an R01 this year and will be expanding that work with them and then designing interventions. Beth Rink graduated about 4.5 years ago, I think, with an R01. She works with Indigenous communities in Greenland and also does work with the Fort Peck community. And they've been working for a long time on sexual and reproductive health. So that's some of just a few of the faculty. We've got many more, but I wanted to highlight some of the ones working with Native communities in Montana and beyond. So, and I want to have a big shout out. So Montana's huge, 600 miles across. There's a ton of what we call windshield time that our investigators spend driving. And this is a nice day for driving, but imagine this in a blizzard coming back, or, pouring rain or high winds. So these investigators travel long distances. Fort Peck is 7 hours from us. I know that's hard to imagine when you're on the East Coast. And the nearest reservation is 4 hours. So it's really a lot of time and energy and heart put in, and they go to these communities for other kinds of things too, for wakes, for weddings, for ceremony, for basketball games, and to be part of the community. So I just really want to highlight the commitments and how much I honor the faculty for all their work. So I'm going to switch now to some of the sort of other work that we're doing in the center. This is one of our training initiatives, and anybody that's junior faculty that wants to apply for this next year, please give me a call. So this is the Promoting Indigenous Research Leadership Conference, and we held this in February of 19 and in October this year. And you can tell it's October because we're just dealing with masking, and we're going to hold it again in conjunction with Don Warren here and his UND COBRE in fall. And that really helps promote junior faculty that are Native or work with Native communities. Another thing we've been doing is we've been looking at the effect of climate change in human health. We have a lot of farmer ranchers in Montana, and drought and wildfire smoke are significant health issues for anybody that works outside, for tribal communities, and particularly for our farming and ranching communities. So we're in the midst of making a couple films based on this work as well. And then, not to forget COVID, we got a fairly decent sized grant to look at home-based COVID testing with the Flathead community here in Montana, and then with the Yakima Latino community in the state of Washington. And so this partnership is with Salish Kootenai College on the Flathead with the University of Washington. And we are just wrapping up that trial, and that aimed to really understand if we could improve home-based testing using trusted community workers versus passive information only using a commercial kit. And so we have a lot of interesting findings. I'm not going to present them here because we're still in process with those, but suffice to say, home testing is complicated and difficult in rural and non-English speaking communities. And then lastly, I want to introduce Herb. Herb is the Health Education and Research Bus, and Herb is a 26-foot RV that we outfitted for having a centrifuge on board, has a -20 freezer, has a space to do physical exams or private interviews. but also can just do educational events. And so Herb drives around the state when possible, doing education and or research collections. And also it's a place for people to stay, because often in many of these rural areas, there aren't places to stay. And so he has spots for at least 4 people to sleep. So I'm just gonna pause here and show you a beautiful story of Highlight, which is about half an hour from my house. This is our watershed for Bozeman. And I think what helps me tie all of this together is that when we're held in a supportive and loving environment, whether that's in a family or a community or in a center, we're really reminded of our true nature, and that we are worthy and we belong, and that everyone deserves to thrive. So I want to finish with one last story, and this is not my story. This is Jennifer's story, and Jennifer gave me permission to tell this story. And I wanted to include it because I really think that Jennifer has taught me so much, and she really embodies belongingness for me. So this is Jennifer presenting at one of the marae at our very first time we were in New Zealand, and you can see how beautiful it is. She's presenting her work in language and culture revitalization. And the Maori were so lovely to her. They treated her like their long lost sister. And she told me later that it was the first moment that she'd realized that she deserved to be treated well, that she didn't realize how badly wounded that she was until she was treated well. And that she felt like communities like hers normalize hurt, and that becomes kind of normative, and that you lose yourself in that hurt. And once she was able to realize that it was really transformational for herself and for her community. And when she got back from this trip, she presented in front of the community engagement work group and really was empowered to enhance and expand her work. And she's presented with me nationally, internationally, multiple times since. And it's really been wonderful to watch her sense of belongingness increase because of that. And I just want to thank her for also being a great travel companion and having such fun with all of our trips. So I think I want to close with this. I'm learning about belonging. I think these teachings have come to me slowly. Maybe I'm a slow learner, but many wise people, many communities and nature have shown me this. And it's a bit like walking a labyrinth, you know, walking toward the center and away, and toward the center and away, like a journey. And I think in this difficult time that we find ourselves in now, with the war in the Ukraine and coming out of COVID and all of the death and grief there, that I think we just have to understand that it's centuries of forgetting that has brought us here, centuries of separation, of domination, of colonization, and the kind of collective loss of ourselves and our belongingness to each other, to the earth, and to our very selves. And I think we're hungry for that belongingness again. And instead of filling ourselves with ideas and things, Netflix and distractions, and becoming members of groups that only reinforce separation and perhaps feed egos, we have to recognize that this longing that people have is really a longing to belong again, to be something bigger, and that belongingness can really heal us. So I think that I have a lot to learn still, but I know that if we're listening, and that if we're still enough to listen, we can hear that deep calling to us to belong again to each other, to our communities, to all creatures, and to the earth. And so I sit now with this question. So how can we help each other remember that we belong to ourselves, to each other, to our communities, and to the earth again? I want to say thank you, and we'll go to questions. I'll go ahead and stop sharing now. All right.
Wow. Fantastic. Thank you, Dr. Adams, for that inspiring presentation. And you covered a lot of different domains with different activities you've been involved with over the course of your career. So there's lots to latch onto and to pull out there. I'll invite all of the participants to feel free to ask questions or make comments. Please use the Q&A function. Just click on that in your Zoom box and you can type those in, and I'll do my best to try to forward those in ways that will allow. We don't have in our webinar format the opportunity to call on you. Specifically, you have to type your question in the Q&A, so please. And while we're waiting for folks to do that, Alex, first of all, this is just such a fantastic overview of your important work, work that actually is somewhat unusual in the sense of how health research is typically done, of course, because you are committed to a participatory approach. And we all know, who are familiar with Indian country at least, that there's really a bad reputation that research and researchers have garnered over decades of inquiry and investigation in which, the researchers themselves were not especially respectful or behaving appropriately to tribal partners. And so, in some ways, colonial subjugation sort of continued to be expressed through those old style of research relationships. But what you're modeling here in the work you've done is a completely different, commitment to participation with tribal partners. It's not researching on them or without their consent, without their engagement. And so I wonder if you can talk a little bit, about the importance of this participatory approach. I mean, you've obviously modeled it, but maybe reflect a little bit about how important it is. And in particular, I think what it means or how it translates into better health outcomes.
Yeah, so I guess I've been doing it for so long, I don't think there's really any other good way, but it took, it took me being taught how to do that. And I credit some of my early mentors for teaching me that. But also I think as a physician, you sit down with patients and you talk with them and you try to figure out what their needs are, at least you should. And I took that same approach into communities. And because I was a family doc, I was used to working within the family structure. So I do think that there are two things that are absolutely critical when people start to work with communities. And I think this is something that we try to model and teach, and having a trusted person go with you into the community is really, really helpful, because they can say, like, don't do that, do this, and here's how to behave. And I had many fond memories of taking students or faculty up to different communities and sort of teaching them on the drive, all the things they needed to know. And that was really, and then modeling that when we got there. But one of the main things is listening, right? Really be a good listener. So you're going up there to listen and understand what the issues and problems are, not coming in with a solution. So that's really the biggest one, right? Because if you come in with a solution, you might as well turn around and leave, because it's not going to be very helpful. So listening for what the issues and problems are, and then creatively coming together with what the next step might be. And then the other one is thinking, what else are you going to do for that community? So I always talk about the give back, because even my students, as junior, sometimes a junior in college thinks they have nothing to give and they're just coming up to learn. But I'm like, we had junior students working at Bad River who knew how to map a watershed, and we heard from the tribe that they needed a watershed mapping. They were there helping build a playground at the time. That's another long story, but they're helping build a playground. And it came up in conversation that they needed a watershed built. And I'm like, well, okay, they could do that. And they did this beautiful drawing and did all of that work, supervised, of course, by a faculty member. But I think that give back is really, really critical. And sometimes the give back is just listening. Sometimes it's physical things like, that watershed piece. Sometimes I would go up and do like all the physicals for the Head Start kids, because I can do those, and and they needed that done, and the other docs were too busy. So those are pieces, I think, that help you understand the community and be part of the community, and then also give something back to the community. So I don't know if that's helpful, but
I think so. Thank you very much. And before we turn to some Q&A, I had another question for you, which is, you've emphasized throughout your presentation the importance of a holistic approach to health. Mm-hmm. And in fact, you showed a couple of instances of a medicine wheel, which is that circle with the colored quadrants. You didn't really highlight that. And our audience is a mix of some Harvard folks and some Native folks. So there's going to be a lot of people who know that, but some who might not. So I wonder if you could just unpack the medicine wheel for us a little bit and tell us about how that speaks to holistic views of health, and why a holistic view of health is different than biomedicine and necessary.
Yeah, okay, so that's a great question, and a kind of a big story too, but I think I don't even know how I first learned about the medicine wheel. Probably various different communities taught me about the medicine wheel, but it's it's a beautiful symbol, and there are actual physical medicine wheels that are found all over the Western United States. There's one that I visited in Wyoming that's near here. I don't know if you've been to that one, Joe. It's just spectacular. And so it has many, many layers of meaning. So I wouldn't even begin to want to get into those because I'm certainly not an expert. But I think in terms of health, what it has to teach us is that you have to look at all of those aspects of health, physical, mental, spiritual, and emotional health as encompassing a person's view of health. So that you can't just look at physical health and say, oh, I've got diabetes, because how is diabetes affecting my mental health? Maybe I'm also depressed. And how is it affecting my emotional health? Maybe that means that I'm not, not getting out of bed and not being able to be the kind of mom or grandma that I want to be. And spiritually, maybe I'm not practicing my ceremony because I'm worried how it's going to affect my diabetes. So the medicine wheel is a concept that helps people understand health in a much more holistic way. And I think Western medicine is sort of coming around. We talk about spirit and mental health, and we talk about physical and health being connected, but we still have everybody all separate. Right. And so we don't do a very good job of that. But I think early on, when we started talking to parents with young children and we asked them what they thought a healthy child was, we got all answers that had nothing to do with physical health. And as a doc, that was really revelational to me, to talk to tribal moms, and they would go, oh, my kid is healthy if they're able to be in a household that doesn't have alcohol and drug abuse, or go to ceremony with us and sit quietly and listen to the elders. And I was just like, okay, this has nothing to do with ear aches or pneumonias, or, it was really awesome. So that concept I've carried with me from that very early research all the way through. And we're trying to teach it in a pretty basic way, Joel, because it's a very layered and complicated and ancient teaching to people who are part of the who are the families within Turtle Island Tales. Yeah.
Well, thanks. And I thought of one other thing to just ask you to clarify a little bit for our audience. Again, most people may have been exposed to this, but you talked about ACEs, or adverse childhood experiences, and they factored and featured in the trauma model, of course. And really importantly and beautifully, you went on beyond the trauma model to do, a well-being model or a health model. So, that's fantastic. But just, can you clarify the importance of ACEs for Indigenous communities? Because everywhere I go, people have found a lot of meaning and support through thinking through and taking, the survey of what adverse childhood experiences they might have experienced in its relationship to health.
Yeah, absolutely. So the ACEs was a study done with a non-Indigenous population, the Kaiser Permanente. And in fact, it was an obesity researcher who realized that many of the people that he was working with would regain weight very quickly, and he wanted to understand why. And so he went back and asked them questions, and very often they were mentioning some kind of abuse as children or some kind of trauma as children. And so they created something called the ACE questionnaire, Adverse Childhood Experiences Questionnaire. I can't remember how many questions are on that questionnaire, but you can Google it and do it for yourself very easily. And that questionnaire covers things like physical, emotional, sexual abuse as a child, other kinds of issues such as death in the family or incarceration of a parent, or other kinds of larger traumatic issues that might happen in childhood. And what they found in that early Kaiser study with thousands and thousands of participants, mostly insured participants, so not a low income group necessarily, was that the score on the ACEs questionnaire, the higher the score, in other words, the larger the number of issues that you had as a child, the more likely you were to have significant mental health as well as physical health issues as an adult. So whether it was alcoholism or whether it was a heart attack or diabetes, your odds ratio was much higher the higher your ACE score is. So understanding ACE scores, I think, is a starting point, which is how Menominee did it, right? We're going to get everybody's ACE score that is either a healthcare worker or works in tribal government or who is in the school system, and just kind of have them understand what their scores are so that they can kind of empathize with what the scores are of people, what the communities is doing. And in many Native communities, I would say a sort of a low score would be in a sort of 1 to 2 or less range, right? But many Native communities, the score is 4, 6. I mean, they're quite high. So, and of course, this is why we have it in the model and why it's such an important concept to understand and to manage, and why it's so exciting that there may be ways that we can modify that with things like belongingness and things like tradition and culture and bringing those things back. So is that helpful, Joe? Did I answer that question?
Very
Okay,
helpful.
good.
Thanks so much. And here we have just a really nice compliment from Delight Satter. Thank you,
Oh,
Alex. Now
hi,
I see
Delight.
how you created belonging for many Native young professionals. My current portfolio includes missing and murdered Indigenous persons and violence prevention, which your work also touches on. I appreciate the work you are doing and loved your point that it took 10 years to more fully understand certain elements of health. No question per se, just many thanks. So I wanted to share that with you because I thought that was very nice. And
That's very nice. And I've known Delight for years. So thank you, Delight. That's awesome.
No, but part of it, what it does raise, I think, is there's a different timeline involved in this kind of research, right? Than the usual kind of biomedical NIH-driven work where you've got your 1 year or your 2 years or your 5 years to do this. And, this either requires a lot of before the beginning work or a very specialized kind of funding mechanism that allows for a lot of collaborative work up front before the research questions are even settled on sometimes. So maybe you can speak just a little bit to that in terms of, especially because you oversee this large NIH funding pot with which to fund grants. How do you manage the timeline differences in academia and in research?
So they're always a frustration. And I'll just say that someday I'm going to write a paper about it and the frustrations, but not yet. Maybe my swan song, because it'll be a complaining paper. But I would say what we've tried to do with the center anyway is to say, let's give people that pilot money so they can start out building those connections, learning how to work with a rural community. How do I work with MSU Extension? How do I work with ranchers? That kind of thing. Or how do I work in a tribal community if I'm not from a tribe? And what does that look like? And how do I build those relationships? So that's, at least a couple of years of that kind of money. And that's about $50,000 to do all of that work each year, right? And then if they want and things go well, then they can graduate to our larger pot of money, which is anywhere from 100 to 150 for 2 to 3 years. That again furthers that collaboration, does some pilot studies usually, and starts to generate some kind of data, some kind of something, and then they can turn that into an NIH grant and then graduate and get their own money, which is 5 years. So if you look at that timeline, that's more like 7 to sort of 8, 9 years to be able to do all of that, which is, I think, a more realistic timeline to be able to generate, NIH funding. I mean, I think that the NARCH grants do this in some ways as well. That's another mechanism that does this, but anytime that you can get that kind of pilot funding to do those relationship building, that's really critical. Yeah.
And maybe just elaborate briefly on NARCH. What is NARCH?
NARCH, so Native American Research Center for Health. So that's a grant that Native communities can apply for, and that provides funding often for projects within the community, mostly educational projects, but sometimes research projects as well, depending on the NARCH. And one of my very first funding was writing the Great Lakes NARCH when I was a junior faculty at UW, and helped get that grant for Great Lakes Intertribal Council. And then the funding helped provide money for us to do some of those initial obesity studies with Menominee and Lac du Flambeau and Bad River.
Excellent, thanks. And that was an innovation by an NIH funded researcher, a Native guy who decided he wanted to figure out how NIH money could go to tribes for tribal control of research. It's an amazing innovation. So thank you. And people have heard about the success stories with the grant that you operate in the center that you run. And one person writes, the NIH piece feels so very hard to tap into for doing this kind of work that we just talked about. How do we connect aspiring PhD students with programs such as yours? And I think this is helpful to spell, like you can't just apply from Florida to get your money, right? So maybe tell us a little bit how that works.
Let me spell that out, right? So we're an idea state. And so idea states are states in the country, there's about 22 of them, that get low amounts of NIH funding. And you can imagine Montana's one of them because we only have 1 million people. So we're not some big mecca. And so being an idea state means that we have to keep the money mostly within the state. So researchers have to be here to be able to get or at least work with us, through us, to get the money for our state. So that's how we promote our own researchers. I would say, but there are idea states all over the country. So look at them, and many of them are states that you wouldn't necessarily assume, like Oklahoma, you know, which is an idea state, right? But has a big medical school. So that's one. The other thing I would say is you need to figure out who the mentors are that are doing this work and reach out to them, because they're going to be able to help you. And one of the things that our university has just done, and Don Warren has started this 2 years ago, I think, at UND, is a Native American PhD program for Indigenous health. And we're just beginning that. Our first cohort will start in this fall, Indigenous and Rural Health PhD. So I'm very excited. I'm going to have my first Indigenous PhD student. Mostly I've just had postdocs or faculty. So we'll be starting that in the fall. And so that's one way. The other way is to look out for different kinds of conferences. Right now, our Pearl conference only is for junior faculty, but there are things for students to think about. And again, if you reach out to folks, they can often hook you up. This is a lot of word of mouth, right? How to do this. When I got to the University of Wisconsin, Joe, there was nobody doing research with any of the tribes at EW, not a single person. Like, that's a huge university, big engine, nada. So I had to create this mentoring committee that had all these great NIH people that understood stuff about diabetes and health and all that, but knew nothing about tribes. My major mentor was Dr. Ann McCauley at McGill. Think how far away that is, right? But I done a little bit with her with the Mohawk community she worked with, so she stayed my mentor. But so I think you can have mentors at a distance. You just have to reach out and find them and figure that out. Hopefully that's a helpful answer to that. And good luck. And it is possible.
Indeed so. And I'm struck by in the couple of the projects you mentioned where you were very closely working with extension agents from the universities. Now, not everyone knows what that is. So can you explain what is extension and how is it that they would be good partners?
Yeah, and so we're just learning how to work with extension. And so the extension system is a really interesting system, and it works a little differently in all the states, but it runs through the land grant institutions. So each state has a land grant institution, like University of Wisconsin was the land grant. Montana State University is the land grant here. And there are extension, what they call faculty, usually master's trained folks that are in every county across the state that do educational outreach and help with projects that need to get done in those communities. Traditionally, people used to think of it as the person that runs the 4-H program, or the person that goes in the field and talks about, you know, new methods for, you know, pesticide control or whatever. But increasingly over the past, I don't know, maybe 10 years or so, extension has been broadening out into health and looking at, again, thinking about more than just ag, because it used to be just ag extension, and now it's really becoming a lot. And so they're doing mental health and they're doing physical health, and they're really starting to branch out. So, for example, I'll give you an example of my husband and one of the engineers' research. They were wanting to look at arthritis in farmers and ranchers because they knew that that was very high, and they didn't understand why. But they had to recruit them to do, and this is so crazy, get blood samples from the ranchers during calving season, which is the most strenuous time of the year when they're out in the cold and the dark, you know, dropping calves, and it's really tough. Well, getting people to volunteer for that kind of study wasn't going to happen with an engineer and a doc from Bozeman. So they reached out to Extension, and Extension had beautiful agents in the field that knew a lot of these farmers and ranchers, or in fact were farmers and ranchers themselves, and were able to recruit enough people for them to be able to do the study and show some really interesting things about their biomarkers. So that's one example. For our Turtle Island Tales work, we are working with South Dakota State Extension as well as MSU Extension to think about how, when Extension does educational programming, how can they reach out to the tribes using this program? So,
yeah, fantastic. Thank you. Here we have a question. What are some action items we can take to start that journey towards belonging and or to support the communities you work with?
This is a great question, and I'm sitting with this question too. I think what I think is that every chance we get, we need to think about how we're all connected. And so that happens in my climate change work, that happens in the work that I do with Turtle Island Tales, and building those really strong relationships between people and building just being really cognizant of the fact that we are responsible for making connections with other people. So even if it's really small, and making sure that you talk to your neighbors, you know, and that you all have a plan for fire season, or, you know, this kind of thing, I think is goes a long way to starting that process. And then once you start it rolling, it's like a ball rolling downhill a little bit. So I think it'll pick up.
All right. Thank you for the presentation, writes another anonymous attendee. Are you working with University of Montana as a partner in your work with Montana's tribal nations? And are you considering your outreach in Montana beyond Blackfeet, Fort Peck, Crow, and Flathead, even to landless tribes?
This is a great question. And yes, some of our investigators do have University of Montana colleagues or consultants on their projects. INBRI especially works with the University of Montana, so our community engagement corps definitely works with them. One of the elders that we work with, Emily Salway, has long wanted us to get involved with some of the urban Native communities in Montana, and we haven't had that opportunity yet, but we're working towards that. I just don't think we've had a project come up that, you know, has sort of fit with what their needs were yet. And then of course COVID has been really tricky to do community engaged work for the past couple of years. What was the rest of the question? I'm trying to remember all the parts of it.
Yeah, just a collaboration with University of Montana. In addition.
I think I addressed that. So, okay.
Thanks.
Yeah.
And other tribal communities beyond some of the ones you mentioned?
Yeah, and that would be kind of some of the urban ones. And then of course there's Little Shell that just came on board. And so we have yet to connect with them, but are hoping to. But again, COVID sort of slowed down some of the out and about that we would like to be doing.
Thank you, yes. And so you explained, I mean, what we're learning a lot here from your presentation is the challenge of doing health equity research in a very rural environment. You know, so the state of Montana, because it's so rural, is eligible for the IDEA funding and is an IDEA state because of that. And then you've really tried to be quite innovative in figuring out how. Do you seed, pilot, research projects, you know, in the Indian communities and beyond throughout the state? And I'm just wondering, you mentioned and explained IDEA, but what about COBRI and INBRI? I don't think you know what those are. So
right. So COBRI is the Center for Biomedical Research Excellence, and it's an NIH program that provides centers like ours 15 years of funding that you have to compete for every 5 years to get. So we're in our second cycle. We'll be competing for our third cycle next year in 23. And then we have to be kind of independent and out on our own. So we have 15 years. So that's what a COBRI is. And there aren't very many. I believe there's only, I think Don and I are the only COBRIs that really do anything with Native health. And he's North Dakota and we're Montana. I don't think there are any other COBRIs. Most of them tend to be very biomedical, very basic science kind of COBRIs. And so we're a little bit outside the box. More are coming online that are doing more clinical and more outreach and more rural, including one in Maine that I consult for as part of their EAC. And then INBRI, I don't ask me to remember the acronym for INBRI, I don't remember it, but it's kind of part of the IDEA network, and it's a much longer, doesn't have a finished timeline, but they are also only in IDEA states, and they reach out to all of the smaller colleges as well as the land grant and the other universities. So they work with like, four-year colleges as well as all the tribal colleges. So they have a lot of relationships with all the tribal colleges, and they're able to fund faculty at all of those other kinds of institutions. So sometimes faculty partnerships that start as INBRI funding, which is smaller and maybe more generative in terms of ideas, will then we'll pick them up and then fund them. So for instance, Vernon was funded like that as a graduate student through INBRI, and then I got him as a postdoc, and now he's on the COBRI, so.
Excellent. I just think it's a really great opportunity for folks on this call to understand better how rural health research is handled through federal funding and so on. So thank you for your patience in answering some of those questions.
I know, it's tricky because I'm like, if I explain all that, it'll take my whole talk. So.
No, it's great. And you mentioned Dr. Don Warren a couple of times at the University of North Dakota. And for those of you who have been watching this series, Dr. Warren was our inaugural colloquium speaker about a little over a year ago. So his presentation is available on the website, just like this one will be in a few weeks. I'm thinking about how one kind of balances challenges and strengths here. For example, you mentioned with regard to the Turtle Island tales, some of the challenges are like family level challenges. And, you showed a slide early on that showed a lot of the health inequities and health problems that our communities face. You got the idea from that closing quote from your partner at Menominee all those years, where you get this really tangible sense that underneath all that we're doing in Indian country, there's this, underlying suffering, that gets talked about and described as historical trauma, and then a search for or healing or transformation of some kind, even as we don't want to tell the same old tragic stories that have become a stereotype of Indigenous communities. So, and I think you've modeled very nicely how to do this, but maybe you can reflect a little bit on the obligation and the kind of creativity and the commitment to really change how we represent Indigenous lives and Indigenous communities through the work that we do.
Yeah, and so that is one of the reasons we got into film. It sounds really funny, but because I think what I was, when we started to look for books for the children in this, so we could give them books throughout the 12 months on each of these health topics, there were no books that represented Indigenous families in a way that talked about these health topics. And particular for sleep, there wasn't a single book on sleep that I felt was worthwhile. So Tassie Parker ended up writing a book with me on sleep that we now use for the kids. But I really felt like the representation just wasn't there. And it was really lacking. And how can kids see themselves unless they see themselves, right? They need to see themselves. So that's one of the things that we've tried to do. And I think through these films, now I couldn't hire a Native child actor because A, the funding is really tricky, and B, I was learning from square one about film. So I was like, if I try to put children actors in, it could get really tricky, but we wanted to have a character that could represent a Native child, which is Igmu. And then he's voiced over by this lovely Crow actor, because the grandmas wanted a nice res accent, and Noah does it great for us. And then Darnell can model sort of good parenting. And so again, they can see themselves with the grandma and with the kiddos. And then we try and put other kind of pictures of kids into videos or into the booklets for the parents, so they can see, again, faces that look like them and get that modeled for them, which I think is really, really critical. But I hear you about the underlying suffering, and I think there's a balance between understanding it and honoring that suffering and why that's there. And as some of my friends say, not getting stuck in the drama of the trauma. So that's all we do is talk about that and not figure out what are the healing things we need to be doing. So what I've learned is to sort of sit with the community and go like, what do you want to do that's healing? And so, for example, when we were doing the first film that turned into the teepee story, we sat with the grandmas, and I thought it was going to be about berries. And we had this whole concept of berries. And the grandma said, oh no, we're doing the story of the teepee. And I'm like, okay. so it all kind of evolved and moved from there. And they do a lot of the behind the scenes kind of making sure that happens in a way that feels, again, honoring of what some of the stressors are, and we address those, but also how are we moving to heal. I hope that's a helpful concept, but I think.
Very helpful.
Yeah.
Appreciate that. So we're nearing the end of our time. I just wanted to give you an opportunity to close on the theme of belongingness again. And one thing that stood out to me, of course, that was a beautiful frame, a way to bookend and trace through the importance of belonging and its potential for advancing good health and well-being. One thing you mentioned at one point was belongingness to place. And, I think there are broad swaths of Americans who can think or imagine what that might mean. I wonder if in Indigenous communities, it might mean something a little more or something a little different than just belonging to other people in the way that we all know, belonging to place even more perhaps than being very familiar and connected to a surround. But maybe you could reflect on belonging to place as we close out.
Well, I guess what I've come to learn, is that from my Indigenous friends, belonging to place this is the place our ancestors are buried. This is the place that we've always been. This is the place that we are related to the animals and to the plants and to the seasons and to the cycles that happen here. So it's a very, very much deeper sense of belonging that many, particularly urban Americans, don't have lost this, right? We might have had some of it when we were rural, but we don't have it anymore. But most tribal communities have people who have that strong sense of belongingness. And that's the piece that I think we need to help Native communities, again, with whatever, pieces that they want to do to engender that, because not everybody has that. When we did a really interesting photo voice study on the Menominee Nation, done with one of my grad students, and he had kids take pictures of like their place. And what we found was that some kids could really have that sense of belonging and really attachment to the Menominee and to the water and to the land and to natural foods, and others weren't connected. And so I think that's some of the work that Jennifer and others there are trying to do, is how to reconnect those kids to their place. So I don't know if that's helpful, but it seems to me like it's just a much deeper concept. And I grew up in New York City, as I said, as a child in a high rise, not connected to much of anything, except that my mother was British and she took me what she would call home every year to visit relatives there. And so for me, that ancestral deep feeling of home is when I'm there, when I'm back home. So I think that we just have to look deeply within ourselves for where we find that. Everybody has that, or the potential to have that. But certainly in Native communities, I think because this is your land, it's much stronger. So.
Dr. Alexandra Adams, we're so grateful for your comments and reflections today, your presentation. It's inspiring work, and it's testimony to the care and commitment you've had throughout your career for Indigenous communities. So thank you for joining us. We're really delighted that you were able to close up our academic year series of Indigenous Health and Wellbeing Colloquia. And just to announce to the broader audience today, we'll resume this sometime in the fall semester. So we're taking a break now. I'm of course grateful to my Department of Global Health and Social Medicine at Harvard Medical School for co-sponsoring this series and for assisting us with this platform and everything that we've been doing to reach a really broad audience. I mean, I think one nice thing about this series is that we've been able to circulate the invitation throughout Indian countries. So we really have an interesting mix in our audience of academic people from Harvard Medical School and Harvard and probably other universities, and tribal and community advocates and professionals and providers and community members as well. So I'm really pleased and proud for the audience that we reach. So thanks to all. Of course, the Harvard University Native American program is obviously very pleased to support this effort as well. It's one of the things that I wanted us to do as a faculty director, to extend into the health field a little more deliberately. And at this point, then let me, with my thanks to my colleague, Scott Podolsky, who obviously has hosted us through this. If there's anything you wanted to say about the seminar series in the department more generally for this academic year, maybe people can learn about that. So thanks all. Thank you, Dr. Adams, again. And Scott, I'll give the floor to you.
No, thank you, Dr. Adams. Thank you, Dr. Gonfer. I mean, this has been a wonderful partnership, getting to co-host these wonderful symposia with you. And as always, learned a great deal today, especially from Dr. Adams and all of you. So thank you.
Bye-bye. Thanks so much.